Hi everyone, I want to talk about anemia. This is a very familiar topic. You've heard about that. Someone has told someone close to you, or might be yourself, that you are anemic, or the diagnosis has been made among the family members, or friends, or acquaintances in any form. Okay, let's go. Today, I will limit myself to signs and symptoms of anemia. Causes of anemia has been presented earlier, and please kindly check that out on my channel. Signs of anemia. When a doctor says signs, it means what he or the nurses could pick. Sometimes what we call signs might be part of what the patient will complain about, which will be symptoms. The symptoms are what the patients will tell us that they have. The signs are what we could pick on physical examination. So let's go. Glossitis and angular stomatitis. We're going to look at the buccal cavity, the mouth region, coming down to the level of my great grandmother right now. So when we find that, immediately we'll be thinking of B12 deficiency, vitamin B12 deficiency or iron deficiency. So glossitis and angular stomatitis are found in B12 and iron deficiency. We're going to check the nails. If it is spoon-shaped, then we'll be thinking of iron deficiency. When we check the abdomen and palpate and find that the spleen is enlarged, then we have a big issue at hand. Are we dealing with leukemia? Is this hemolytic anemia? Can it be lymphoma? Or, a milder situation, this is an infection. So when there is splenomegaly, then we need to find out whether this is leukemia, hemolytic anemia, lymphoma, or infection. Sometimes we are going to see jaundice. We check the sclera, check the skin, check everywhere, it's jaundice, or maybe we even do the laboratory investigation and we find unconjugated jaundice, and so on and so forth. Then quickly our brain will go down to, is hemolysis going on somewhere? Then we're going to do some other tests like haptoglobin that is expected to drop if there is intravascular hemolysis or increased LDH and so on. We're going to rule out other causes of jaundice like liver enzymes and liver function tests to know what's happening to the liver. When all those are out, then hemolysis, liver failure, or aplastic anemia will be sure of why we have the jaundice. Okay, the patient has come down. We are thinking of possible thalassemia minor or major. And that could be beta thalassemia or alpha thalassemia. We're going to find out among people from Mediterranean, Middle East, Africans, and so on. When we check all the major regions of lymph node and we pick lymph node enlargement called lymphadenopathy, then we'll be wondering, are we dealing with leukemia, lymphoma, or HIV? Don't be scared. It's not everyone who has lymphadenopathy that has HIV. It could be leukemia, could be lymphoma, could be infection, but more about HIV, leukemia, and lymphoma when there is lymphadenopathy. If the patient presents with petechiae, purpura, or ecchymosis, Immediately we'll be thinking, what? Is this autoimmune hemolytic anemia? Are we dealing with decreased platelets or thrombocytopenia here? Is this hemolytic uremic syndrome or there's bone marrow aplasia? We want to find out. Now, if the major problem is ulcers at the lower limb, oh, we want to know what is the genetic constitution here. Is this sickle cell disease? Is this SC or are we dealing with thalassemia? Okay, still on a physical examination, there is hyperpigmentation and this person is having anemia. We want to know if this is Fanconi anemia. So hyperpigmentation is associated with Fanconi anemia. But if this is a black woman or black man or African American, if you are in the United States, then you are thinking of sickle cell disease. You want to find out if this individual has been having chronic pain, which will be a form of vaso-occlusive crisis. You want to see how pale he or she is, swollen hands and feet, bursting fontanelle, acute chest syndrome, pain in the chest region, aplastic crisis, and sequestration crisis that I'm going to present on separately. There will be a separate presentation on sickle cell disease anemia. Please watch out for that in future. So I'm not going to spend all the time on that right now because sequestration crisis could kill within hours. Sequestration crisis in sickle cell disease could take their lives within hours. The symptoms. Now the patient has come to see me at the clinic and the individual could be complaining that I have bleeding through my nostrils, epistaxis, or I've been told that I'm pale. And if I say, who did? I say, oh, my family members, my friends at work, or my neighbors. Or I have fever, cough, discharge, confused, particularly if it's associated with vitamin B12 deficiency, and also neuropathy with B12 deficiency. Tinnitus, jaundice. Urine is colored for the purpose of jaundice or melanoma because it's bleeding from upper GI or frank blood in stool, hematochezia, hematemesis, vomiting blood, fainting when the effects of anemia will set in, fainting, decreased blood pressure, splenomegaly, fatigue, lightheadedness, weakness, tiredness on exertion, palpitations, dyspnea, dizziness, and syncope. The individual could be fainting and falling down, and it's dangerous to be driving when you are anemic. In conclusion, there have been more presentations on anemia because it's a very serious problem on account of which many people have been admitted in the hospital or they've been visiting their family physicians on frequent basis. G6PD deficiency, folate deficiency are already published. Please check out. Iron deficiency, vitamin B12 deficiency, autoimmune hemolytic anemia will be out in the next few days. Thank you for listening to my presentation. Kindly subscribe so that you can get this immediately they are published. Thank you.